due to an ischemic cardiomyopathy or in the majority, large proportion of cases, non-ischemic DCM. We see tethering and restricted leaflet motion due to systolic LV impairment, and so any LA dilatation you see in that scenario is relative. Atrial secondary MR is a different group, characterized by normal LV systolic function. And what we see is generally a central regurgitant jet with normal leaflet motion, but marked severe LA dilatation. And we've already touched on this in the earlier talk, that the pathophysiology is complex, the population is heterogeneous, and what drives this is, of course, the underlying factors for HFpEF and AF. And it's absolutely vital that attention is paid to strategies around controlling all the etiologies of HFpEF, hypertension, and the like. So if we dive into this in a bit more detail, of course, the data bear this out, and we've spoken about the high level of evidence and indication for ventricular secondary MR. It's important to note that for atrial secondary MR, we have data, we have registry data, we have observational data. We know we can do it, we can put clips in, we can reduce the MR. The level of benefit is harder to predict. The durability of that benefit is harder to predict. We have not had any randomized trials, and so that's why this is a class 2B indication. Within this atrial SMR group, there is some understanding of the anatomical changes that occur, which reflects the severity of the disease. As I've highlighted, fundamentally what we see is the mitral annular plane dilated. Now, if this progresses, what we can then see is an asymmetry where the posterior annulus is pushed outwards towards the LV posterior wall. And so you see what has been termed an atriogenic tethering or hamstring. And we can recognize that echocardiographically as a tethered, often restricted looking posterior leaflet, but of course not due to any region wall motion abnormality in the LV. This is related to the progression in mitral annular plane changes. And it is important to recognize those subgroups. And I'm not going to talk about that in more detail. We can perhaps talk about that in the discussion. But I'm going to touch upon that in my concluding remarks. I'm going to give you a case example of a patient that we've treated. This is a 75-year-old male who had presented twice now in 12 months with decompensated heart failure, so both pulmonary congestion and peripheral edema. Background history of previous CABG, permanent AF, preserved ejection fraction, other comorbidities including hypertension, diabetes, CKD. This is our bread and butter patient that we get day in, day out, older age group, higher prevalence. We're seeing an epidemic of AF and HFpEF. We are seeing more and more of this subgroup. And he was optimized, rendered euvolemic but requiring IV diuretics, had GDMT, and was referred to us by a nearby hospital, given that this was now his second admission. AF control had been good, QRS, duration normal ECG. And just to show the baseline echocardiogram, which reveals preserved LV systolic function, you can see that there is marked LA dilatation and a severe MR jet. And there's also coexisting tricuspid regurgitation. We went on to do a TEER, which gives you a bit more understanding about that subtype of atrial secondary MR. There is some leaflet degeneration, but certainly no prolapse, no flail, where we could consider this was a primary DMR. This was secondary MR. Ventricle was normal, related to isolated atrial dilatation, annular dilatation, and the etiology of the TR exactly the same. Now, we can talk about strategy going in and which clip to use. And there is a rationale for both clips, I think, in this scenario. There's an argument for saying that the mitral clip gives you a greater annuloplasty effect, that active locking mechanism. Equally, there's an argument to say, well, Pascal is less traumatic on the leaflet, so we know that there is maladaptive leaflet changes where it might be quite beneficial. And in this case, I planned to go in the middle with the P10, which has that spacer, preserving that relatively atraumatic approach. So it was a relatively straightforward procedure. We didn't have that atrial tethering, which can make it challenging. In those cases, sometimes it's useful to create a little bit of perhaps an aortic hugging effect if you're struggling with the posterior leaflet. This was down the middle, good leaflet capture, orientation good, closure, and we got a very, very gratifying result. We got really trivial MR. And that I would say, I would point out for all cases, we should be monitoring the hemodynamics, we should look at multiple parameters in order to understand our results. So with residual trivial MR, there was an LAV wave reduction by 50%. Interestingly, the blunted pulmonary venous flow didn't change, it wasn't fully normalized. We did see a bump in the systolic blood pressure, and we maintained a mitral valve gradient below 5 millimeters of mercury. Follow up at 2 months, and we had early effective outcome, minimal MR. The TEER is now moderate, keeping that under view, critically remains on medical therapy, and clinically a good outcome in terms of functional results. And importantly, must continue not only on heart valve disease surveillance, but heart failure management. So to conclude, I think it's important to recognise this as a distinct condition, but one where we still have many questions. But it is a distinct condition. There are some marked anatomical and functional alterations. We see lots of these in our referral practice. And so we do have to make some decisions about how we're going to apply. Certainly what in my practice, we have constraints. I have constraints in terms of number of procedures I can do in a week. Who is it that we should be treating? Which is the patient group in whom we're going to get the most effective outcomes? And in that sense, understanding those subtypes is important, because we do have some data which indicate in that atrial tethering hamstring group, they are a worse group in terms of TEER outcomes, in terms of effectiveness of outcome, durability of outcome, and mortality. And so perhaps you can apply that more refined approach in selecting these patients. Must emphasize the importance of heart failure therapy and AF management. And to that earlier point, I think early restoration of AF of sinus rhythm is important. That interaction with our electrophysiologist is certainly gaining traction. It's not a benign condition, and this is something that I think we need to focus on. We certainly need more data. We need trials to look at even the pharmacotherapy in this group, not just the role of TEER. And it may well be that we have to look at alternative mitral valve therapies in more advanced cases. And finally, patient counselling is important. MR, as you all know, is a heterogeneous group, and it's vital in this group that they understand that there is more uncertainty, both in terms of how effective the procedure may be, how durable it might be, and indeed what sort of response they may get to our MR reduction. Thank you.